And we do want to mention that we are recording this session, so please don't include any confidential patient health information during the session, especially when discussing any cases. Also, in just a moment, I'll put up Dr. Goldblum's email addresses in case you have questions for him. And as well as we'll get through our housekeeping slides here. So, there we go. Just some general healthcare or telehealth guidelines. Just be aware that as soon as we make you a panelist, you will your camera will come up and your microphone will be enabled. So down in the left-hand side of your Zoom screen, you'll be able to mute those and unmute those. So if you prefer to do that during the presentation, we would appreciate you muting your mic, and we'll go ahead and do some questions at the end. If you do want to receive CME CEU certificate, please, you can, somebody's having some trouble. Okay, Dr. Ciudad, you may just need to unmute your computer speakers. Let's try that. We are broadcasting, and I'll type you a message here in just a moment. We'll have to push through our slides here. So we do need you to let us know that you're out there, and where you're from also would be great. You can use the chat box, or you can unmute and let us know that you're there in just a moment. Here's some brief instructions on how to start and stop your video and your audio. Our disclosure and accreditation statements, we're required to put those up for CME offerings. And we do offer case consultations through some of our programs with Molina and Blue Cross Blue Shield New Mexico. So if you're interested in that provider-to-provider consultation, they are reimbursable up to $150 from Molina and $75 from Blue Cross. So take advantage of that. And at this point, if you can unmute and let us know that you are there. Otherwise, please type anyone who's in the room with you who would like credit. Make sure that you get them credit as well. So we'll give you just a minute to do that. It looks like we have some people signing in. Go ahead.
This is Richard Stam. I'm a retired pediatrician from Gallup. I live in Albuquerque now.
Welcome. Thank you for coming. And looks like we also have Sherry Dodson, Jackie Good, Melissa Mason, Chelsea Guyen, and Hernan Ciudad. And hopefully you can hear us by now, but I'll send you a chat here in just a moment. And without further ado, I'm going to go ahead and turn it over to Todd Goldblum. Thank you very much.
Great. Thank you. I am a pediatric ophthalmologist here in Albuquerque at Family and Children's Eye Care Center. Also, I am at UNM. I will be starting to run some pediatric ophthalmology clinics there starting in November. Financial disclosure. I have no financial interest in any of this material. I do want to emphasize that all of what I'm presenting is not my opinion, but it is actually fact. And this talk actually mirrors this policy statement from Cheryl Handler. It's actually a friend of mine. She authored this back in 2011. And this is the official policy statement from the American Academy of Pediatrics regarding learning disabilities, dyslexia, and how it relates to division. I've got a lot of slides here. I may not be able to get through all of them. And I will save some time at the end for questions. And also, we're going to provide my email address in case you need to contact me with any other questions. We do have some handouts that are online, and also the slide presentation will make sure that that's available online too. But this one, which is part of the handout, actually mirrors my talk. So Dr. Seuss said it right. The more you read, the more things you will know, more places you will go. reading is very, very important. This is sort of the outline of my talk. I'm going to first talk a little bit about language development, then how the eye and vision relates to reading, a little bit about dyslexia, different treatments, role of the pediatrician. The pediatricians that are listening here know these early speech and language milestones. A delay in these milestones may indicate a future learning problem. The way a child learns our language is a sequence that first starts with understanding our language, speaking it, then comes reading, and then comes writing. Oral language is the foundation for reading, and I can't emphasize how important that is, and this has been proven out by many studies. It is extremely important for parents to begin talking to their child in infancy. Hirsch, in his 1996 study, found that oral skills, language skills, does mirror reading skills. Okay, so is there, I don't have a pointer here. But here we go. Oh, here we go. Good. Okay. So on this is the chronological age, and this is the reading level. Okay. So those who had a low oral language correlated with a low reading level. Very important that this is stressed to parents. Speaking and reading to the children right from infancy, 100 stories before they can read is ideal. Children who develop these literacy skills definitely perform better in the primary grades. We're recommending reading to children just 20 minutes per night. Gives a 10-point increase on literacy tests. Very, very important. Oral language is very different than reading. Oral is pre-programmed, okay? It is innate, something we are born with. Reading is not. Reading is something that is learned, and it is one of the hardest tasks that we ask children to do. What is reading? Reading is, you can also think of it as decoding. We are decoding. We're taking abstract, man-made symbols and converting them to language. It requires good vision, memory, attention, and the ability to name objects rapidly. These are the four makeup, or I should say reading is comprised of these four main areas. I'm going to go over all four of them. The first one is orthographic perception. An infant very quickly will learn that an object presented in different orientation is the same. So an infant very shortly will be able to recognize that this picture is a dog, no matter how you orient the picture. Well, this is why our language is so difficult, or not our language, but our written alphabet is so difficult for a child at first, because to them, a B is going to look just like a D and a P and a Q because of this that they have learned. And they have to learn that orientation here does matter. Learn to read.
One moment, I apologize. Okay, looks like we had a network stoppage. My apologies. We'll get this guy back up here in one moment. Everyone else connected back up. Can everyone hear us? Thumbs up if you can hear us. Great, thank
See
you.
one thumbs up, yeah.
Thank you so much. We'll get this guy going here.
Here we go.
Okay. Now, do you want the slides back up?
If you can.
Again. So sorry, Dr. Goldblum, I'm not sure what this is about. Okay, I think we are back. Let's get your buddy.
A little feedback.
Yeah, let me see if I can isolate that. All right, I think we're good on the feedback. If anybody is unmuted, you may want to go ahead and mute yourself at this point. And we will try this again.
Okay.
Interesting.
Yeah, keep going. Keep going. Keep going. Wherever there, orthographic. Okay, there, and keep going. Oh, okay, back. This is where we were. Okay, so a sound may be represented by different letter groups. Okay, so long A sound could be spelled in many different ways. Several sounds may be represented by the same letter group. So OUH can sometimes be the O sound or the through, which is a particular O sound. Tough, that's UF sound. Plow, OUGH makes the OW sound, and hiccup makes that sound. So it's very, very complex, the way our written language is put together. For some children, the process of decoding is so laborious and time-consuming, they are unable to understand what they are reading. To sort of give you an example of how difficult decoding is, for us, when we pick up a newspaper or a book, it's very, very easy. We have mastered the code, but let's pretend that that you're a child and you're learning a new language, and let's take our and the Russian alphabet here and give it a phonetic equivalent to our English language. And for example, let's say we wanted to spell pen phonetically in Russian. This is how you would do it. Okay, so very quickly, how fast can people decode this? Okay, it would take everybody a good 10, 15 minutes to go ahead and decode this. Okay, this is what a child sees. So what that means is decoding puts heavy demand on working memory when not automatic. Okay, so this is what kids are going through when they are learning to read. It is a code that they need to learn and to master. The mind, our brain actually does a lot of the work in putting things together. This is pretty amazing, but this paragraph, which is totally butchered, even though it is spelled very incorrectly, our brain is able to fill in the mistakes and make sense out of this. So the brain does a lot of work for our reading and decoding, even if it's not completely accurate. Fluency is the ability to read the connected text rapidly, smoothly, effortlessly, with little conscious attention, okay, to the mechanics of decoding. So this comes after decoding is fluency. Obviously, a child must become accurate decoders before they can become fluent readers. Fluency involves sight words. Okay, these have to be practiced many, many times and to be committed to memory. The sight of the word activates a pronunciation without sounding out or blending the phonetic sounds together. So a child must be able to see or recognize a sight word. They must be able to see it 4 to 14 times before committing it to memory. A child who has dyslexia will require 40 to 100 or more exposures to be able to recognize sight words to allow for fluent reading. This is sort of what it's like to be dyslexic. You can see how this is broken up. It doesn't come together, and the reading is labored and non-fluent. Comprehension is the last bit of the reading skill that a child must master after fluency. Comprehending what they are reading, that requires intelligence, reasoning, vocabulary, syntax, grammar, as well as attention, memory, knowledge. I'm not going to go into this. That is explained a little bit more, in more detail in the handout regarding comprehension. Okay, so I emphasized with language development the need for good oral language skills first, and that our language is a written code that a child must need to be able to decipher and master. I'm now talk a little bit about what are the eye and visual functions that are necessary for reading. You do have to be able to see what you're reading, after all. It does require these 5 skills, which I will go over. Visual acuity is the sharpness of sight measured at 20 feet, 14 inches. Everybody I hear is familiar with the different refractive errors. Refractive errors can interfere with reading, but usually they really have to be very, very large refractive errors to do that. The one good thing is that our print that is started out in school is very, very large. So kindergarten books have a 26-point font, and that corresponds to a visual acuity of 2200. So child really, when they start out, really it's important to have good vision, but it can be somewhat blurry, and they should still be able to make out the print. Obviously, the finer, smaller fonts become more important later in age. Larger print and spacing helps all readers, especially those who have reading difficulties. We also require accommodation to be able to read, which is when the lens of the eye focuses, and then convergence, where both eyes turn inward to look at the same word. Accommodation is the lens becoming fatter in the eye to put the focused image on the back of the eye. Accommodation decreases with age, that is the focusing. A child who is 6 has roughly 10 times the ability to focus than somebody who is age 60, which is one of the main reasons why children almost never need reading glasses, yet I see them prescribed all the time, okay? So remember that. Children have 10 times the ability to focus than somebody who is age 60. That's why most adults need reading glasses or bifocals as they age. Young children, you will see them holding books very, very close to their face. It's because it makes it bigger. Everybody likes bigger objects to see. They do it not because they can't see it from further away, but because it's easier and more pleasant to see a larger object, and they can do it. Most of the people listening here cannot do that anymore, but children can. They can hold something 1 inch from their nose and be able to see it clearly. Most children are farsighted, 1 to 2 diopters. It is normal. They do not get glasses unless they're having some sort of other problem like eye crossing. Children who have larger amounts of farsightedness, which we sometimes will see, may have difficulty focusing and need glasses. But by and large, most children who are farsighted do not need glasses. Convergence is the eyes turning inward so that both eyes are looking at the same target. It is needed for reading. However, if a child has convergence insufficiency, which first of all is very, very uncommon and frequently undiagnosed, convergence insufficiency does not interfere with reading comprehension. It may make it more uncomfortable to read, but it certainly does not decrease the decoding fluency, reading comprehension, all of the points that I mentioned earlier. I have children who come in all the time diagnosed with convergence insufficiency. The majority of them do not have it. It is very, very overdiagnosed. And if you see a child who has it, you may want to ask for a second opinion. Convergence insufficiency does not cause dyslexia. And again, it very uncommon. It does not interfere with decoding or comprehension. Okay, so I measured visual acuity, accommodation, convergence. The next part of the eye and vision process that is needed for reading are saccades. Saccades are small jumping eye movements that take our eye from one word to the next, okay? It's also used if we see an object in the periphery. It brings our eye from that image that's in the periphery right to the center. This is a very, very fast eye movement. Reading uses forward saccades. 85% of our eye movements when we're reading are forward saccades, which in our language is left to right. In Hebrew, Arabic, it is the other way around. It is right to left. Backward saccades are about 15% of our saccades. They increase with difficulty of the text, that is rereading, trying to understand it. It's also, backward saccades are also used to jump to the next line. Reading is composed of fixations, which is less than a quarter of a second. Some words require more than one fixation. After the fixation is made, information is analyzed, and then we make our saccade, which moves our eye to the next point of fixation. Again, this is a very, very rapid eye movement. This is an example of forward saccades, somebody who is reading this paragraph. Here is the backward saccade, here forward, forward, forward. Oh, I didn't get this. I have to reread it. Backward saccade, read it again. This is eye movement recording of a person reading a newspaper column. You can see all the forward saccades, and then there's some backward saccades. So again, this is confirmed that by eye movement recordings that it is saccades that take our eyes to the next word, not tracking, which I'm going to mention a little bit later. Tracking is not used for reading. That is a big surprise to almost everybody who I must see 10 patients a day who come into the office who are sent in by their teacher or occupational therapist because of tracking problems, which are extremely rare. Tracking is not used for reading. I'll explain what tracking is in just a minute. Children, when they are learning to read, show very, very similar saccadic and fixation patterns to dyslexic readers. That is, the saccades are very, very short. They make more frequent backward saccades, and their fixation is twice as long and twice as often. Dyslexic readers show normal saccadic function when not reading. For example, when they're playing video games, their eye movements are completely normal. The eye movement differences between dyslexic and typical readers are the result, not the cause of their dyslexia. That's why teachers will say the child's eyes are moving all over the page. They are, but that's not the primary problem. That is a secondary cause of dyslexia or a reading problem. And this pattern, this abnormal saccadic and fixation pattern, does improve when the reading skills improve. So this is showing a normal eye movement recording with a person, a normal reader, and then a dyslexic reader, more saccades, more backward saccades, more fixations. The saccades are shorter. What is smooth pursuit? Smooth pursuit is eye tracking. This is what everybody gets all upset about, and children are misdiagnosed with this all the time. Smooth pursuit is a very, very slow eye movement. It keeps a moving object on the center of the retina as it is moving. It is for moving objects. Our books are typically not moving, okay? It is the saccade that moves our eye from one word to the next. Slow eye movements or tracking is a very archaic, rudimentary eye function or motility function that is rarely used. We rarely use smooth pursuit or eye tracking. Most of our eye movements are very, very fast, rapid, saccadic movements. Smooth pursuit is not involved in reading, and this has been confirmed by eye movement recording. So this is fact. This is not my opinion. Even though you will read and hear out there about tracking, I was out traveling to England, and this is worldwide. And somebody came up to me at a reception and said, "Oh, you're an eye doctor. I understand that tracking is a big cause of reading and dyslexia in children." And it was like, wow, this is just worldwide, that this misconception. You tell something that is false often enough, people start to believe it. Children can be good readers if they have reduced vision, okay? We have plenty of children who their best corrected vision may not be 20/20. We may only be able to get them to 20/60, 20/80. They may have albinism. They may have all sorts of different problems with their eyes, and they're good readers. Children can be good readers if they have strabismus. Strabismus does not interfere with reading typically, and that is because the brain will suppress one eye in most kids with strabismus, and you only need one eye to be able to see what you're reading. Nystagmus, it's pretty amazing. Children with albinism or even idiopathic infantile nystagmus, they can have pretty bad nystagmus and they can read just fine. Learning to read is rocket science. As I mentioned, it is one of the hardest skills that we do ask children to be able to do. I'm going to move on a little bit to dyslexia. This is the very common problem that teachers, pediatricians, anybody who works with school-age children face. They're struggling with reading. Phonics are not hot, math is easier. They say that the words are moving, they're skipping words and lines. The teacher will say that the eyes are moving all over the place. Teacher will say there's got to be an eye problem here. It's got to be the eyes are moving all over the place. They've got something wrong with their eyes. Friend says, okay, well, they must go and receive vision therapy from a developmental optometrist. Back in 2000, the National Institute of Health put together experts from around the world to look and research how are our eyes used for reading and what causes dyslexia? What causes children to have reading problems? The first thing that they found is what I explained in the first part. Children need good oral language skills. They must have phonemic awareness, fluency, vocabulary, and reading comprehension. They also found that learning disabilities are extremely common, and it can occur in up to 20% of the population. What they found is that learning disabilities arise from neurologic differences in brain structure and function. And I'll show you a slide later on, but Sally Shaywitz out of Yale has actually done a good portion of her research on the neurobiology of dyslexia. Dyslexia is a miswiring in the brain, and with her functional MRI scan, she has shown that this is the case. Learning disabilities can involve all sorts of language functions, the most common obviously being dyslexia, which is a problem with reading. Reading difficulties early in reading can have many different causes. If a child lives in an environment where there's deficits in oral language, that's going to have an effect on the reading. If they have inadequate instruction, there can be other causes besides dyslexia. And usually, dyslexia is a diagnosis of exclusion. One of the most important diagnosis to rule out in a child who has reading difficulty is attention deficit disorder. Reading requires obviously a lot of attention, and it's, I'm going to show you some slides here in a little bit, but dyslexia can be seen in conjunction with attention deficit disorder. Dyslexia is defined as a specific learning disability that is neurologic in origin. It is not vision-based at all. It is a result, from a deficit in the phonologic component of language that is often unexpected in relation to other cognitive abilities. These dyslexic people tend to be very, very smart. They have weak decoding skills. It makes reading and writing very, very difficult, very, very laborious. Dyslexia is the most common learning disability. Up to 20% of children have some degree of dyslexia, which means some people who are listening to this presentation have dyslexia and they know what I'm talking about. Dyslexia runs in families. It is not related to intelligence at all. In fact, it is just the opposite. People who are dyslexic are often very, very bright and very, very analytic. I'm going to give some example of some famous people who have dyslexia. Dyslexia is not all or none. It is a spectrum. You can have very mild dyslexia all the way up to very, very severe dyslexia. Kids do not outgrow dyslexia. Adults who have dyslexia still have struggle with reading, and this has been shown by Sally Shaywitz. Sally Shaywitz has shown that people with dyslexia, their brains are wired differently. I'm not going to go over this, the neurobiology of reading. I did include Sally Shaywitz's article in the handout, and anybody who wants to can go ahead and read the neurobiology, but just to sum it up, it's a disruption of the posterior reading symptoms. As I mentioned, dyslexic people tend to be very, very bright. It leads to out-of-the-box thinking. A lot of very famous entrepreneurs are dyslexic, leading to breakthrough technologies in science, technology, engineering. As I mentioned, dyslexia is a problem understanding written words, separating the sounds, sight word recognition, problems with fluency, problems with comprehension. It is not a vision-based problem. It is a problem interpreting the words. Eye or vision problems do not cause dyslexia. So a child who has misaligned eyes, they have strabismus, they have jerky eye movements, abnormal focusing, they have no higher incidence of reading or learning problems than any other child who doesn't have these problems. Okay, so vision problems, yes, there may be some vision problems that interfere with reading, but it's pretty unusual. Again, children with dyslexia do not have more vision problems than children without dyslexia. Some misconceptions. People with dyslexia do not see things backwards. Word reversals and skipping words are due to the dyslexia, the linguistic deficiency, not a primary visual or perceptual disorder. Okay, again, teachers will say it's got to be the eyes. They say that that words, the page is moving, lines are missing, they're skipping lines. It's got to be the eyes. That is incorrect. It is secondary to the linguistic dysfunction. Again, I'm going to emphasize this again. Some people, there is no eye tracking problem in children who have dyslexia. Again, tracking problems. I'm going to go back to my office and I'll have 2 or 3 kids waiting to be seen for me to evaluate their tracking problem, which I have never, ever seen. Fluent reading has to do with decoding abilities, naming, comprehension, memory, and attention. Tracking problems are overdiagnosed. It is not, dyslexia is not a vision-based disorder. If it were, why do kids with cerebral palsy, strabismus, amblyopia, or nystagmus, why do they achieve the same reading level as children without those conditions? The other thing to think of is if a child with dyslexia, if it were a problem with the eyes and the motility, why then are they so good at video games? Okay, they will master a video game which requires tons and tons of eye-hand coordination and motility skills, much more than even reading. They have absolutely no problem doing video games. Indications of dyslexia, family history, speech delay, difficulty with rhymes. These are some clues as to a child, a toddler who may later develop a learning or a reading problem. These are other signs of dyslexia. Dyslexia can be associated with other problems. Attention deficit disorder is the big one, 20 to 40%, and vice versa. They can also have these other problems that I have listed. Attention is exceedingly important when it comes to reading. That's why children with attention deficit disorder do have reading problems. A child with behavioral issue may have reading problems, and adults may mislabel these children as lazy, underachiever, a problem child. By the time a child is found of dyslexia, they may already be labeled as stupid, which is actually completely false, and it's usually the other way around, and have a damaged self-esteem. They may be teased, they may develop low self-esteem, they may be bullied, and then you get into this vicious cycle where they have difficulty reading, they don't want to read, and it just is a spiral downhill. Unfortunately, many teachers are receiving only a cursory introduction to reading instruction. And right now in our public schools, we have a delay in assessment and intervention to reading and dyslexia. We have what is called a response to intervention method, which Sally Shaywitz calls wait to fail. They're put into different curriculums, different programs, but none of these children receive a thorough workup until they are in second, third grade. And by then it may be too late. Again, this is called Watch a Child Fail. The International Dyslexia Association is working to improve this teacher training, developing practice standards, as well as screening children for dyslexia in the classroom. Again, I'm not going to go over what the screening process is that is recommended. It would be wonderful if all schools in New Mexico could do this type of screening. I believe if you talk to most teachers, they will tell you that vision screening in children is how we look to see if a child is going to have problems with reading, which is completely false. Yes, good vision is necessary for reading, but again, the majority of children who have dyslexia are going to pass the vision test. The visual acuity test is not a screening test for reading and learning problems whatsoever. Teachers who have been trained in science-based reading intervention screening are improving the reading scores. Delaying identification is penny wise, dollar foolish financially for schools. The screening, this is the basics of it: alphabet recognition, phonemic awareness in kindergarten, identification and fluency in first grade, oral reading fluency in second grade. Diagnosis and treatment usually requires a team to be able to diagnose what is going on. And there are people out there who will say, okay, your child is having reading problems. It's got to be an eye problem. They need to go to a developmental optometrist for vision training. And nothing is further from the truth. Just because a child is not able to learn or read does not mean that they have dyslexia. It certainly would be the most common cause of the problem, but you don't know if that child has attention deficit disorder. You don't know if there's terrible social situations at home. You don't know if there is a behavioral problem. There is the unlikely probability or possibility that they may have an eye or a hearing problem causing it. So usually what we recommend is a person at the bottom that's our go-to person is the neuropsychologist who is working to figure out, okay, what is the diagnosis? Once you come up with the diagnosis, then you can go ahead with the proper treatment. Why is early screening and remediation important? Studies have shown that if children who receive the proper phonologic and phonemic training early, like kindergarten and first grade, only 10 to 25% will continue to show problems. But if it's not identified till third grade, it is close to 3/4 of them will continue to show significant problems in high school. So while the child is fooling around with vision training, if the parents say, I want to give vision training a few years to see if that works, that is actually causing harm because they are missing out on this window of opportunity to receive the proper phonetic treatment. I'm not going to go over the treatment of dyslexia. This is not my area of expertise, but it does involve phonemic awareness, phonics, vocabulary development, all the topics that I spoke of. Dyslexia, as I mentioned, is a lifelong condition. We are going to be running out of time soon, so I'm going to go through these slides sort of quickly. We've gotten through the meat of this. Allowing for extra time is obviously Important if a child has attention deficit disorder, important to treat that. As I mentioned, dyslexia, people tend to be some of the brightest people in the world. These are some people who have dyslexia. Albert Einstein, for God's sake, had dyslexia. One of the most brilliant people that ever lived. Controversial treatments. I mentioned the proper treatments for dyslexia: phonemic and phonologic awareness. That is what's recommended by the American Academy of Pediatrics and the National Institute of Health. Again, that's not my opinion. This is, I'm just explaining what is recommended by our national organization. There are many controversial treatments for dyslexia and a lot of sham treatments. If a study does not adhere to prior scientific rigor, you can make it show whatever you want it to show. Very often, public dissemination of fact, very often, dissemination of fact is, sorry about that. Published studies may be invalid. Don't believe everything that you read. Here we go. This is from 50 years ago. These physicians recommend Lucky, cigarettes. Aircraft noise makes you fat. Healthy for women to sunbathe, according to this Swedish study. A treatment is controversial if it is released before research has validated the treatment. Where's the control group? And a lot of the vision training studies and Irlen or scotopic sensitivity syndrome studies are very, very poor studies. Scotopic sensitivity syndrome is not taught in any major university. For all practical purposes, it does not exist in the mainstream academic community. Supporters report that it accounts for half of people with learning disabilities. It was started by Dr. Irlen decades ago, based on using colored lenses for different types of dyslexics. Before any good research was done on it, it was presented on 60 Minutes. The treatment, the tinted lenses are used because of presumed perceptual dysfunction causing visual distortion and sensitivity, particular wavelengths of light, now called visual stress. I'm an ophthalmologist, a pediatric ophthalmologist. I have no idea what this means. I have no clue what that means at all. Tinted lenses are also used to treat all of these other conditions, if you believe it. We're getting toward the end here. We do have many studies that show that the scotopic sensitivity research, those all have serious flaws and are invalidated. Again, this comes from the American Academy of Pediatrics as well as the American Academy of Ophthalmology. Any benefit that they have is the result of a placebo effect. A lot of the trials are done in conjunction with treatments which have been proven to work, such as phonemic awareness. So they'll use colored lenses in conjunction with phonologic awareness, and of course, the child improves. Vision therapy, likewise, vision therapy is an attempt to improve visual skills. It is done usually in an optometrist office, 30 to 60 minutes. It involves all sorts of visual spatial skills, rotating peg ball, chasing the ball, jumping jacks, windshield wipers, beanbag, slap, tap, doing chalkboard circles. I want to emphasize that this vision training is completely different than the good work that the people at the New Mexico School for the Visually Impaired do. The vision help that they do is for children who are visually impaired, which has been scientifically shown to benefit our children, and we all owe a big appreciation for the people at the New Mexico School for the Blind. That is vision help in a much different way. This is taking children who see 20/20, who have no vision problem whatsoever, and have them do these sham sort of treatments, and it's called vision training. It is not the same as what the good people at the New Mexico School for the Blind and Visually Impaired do. American Academy of Optometry, vision therapy does not directly treat learning disability, but it is to improve visual efficacy and visual processing. This sort of means, well, it works, but it sort of doesn't work. A very good study in 2009 looked at a majority of the vision therapy studies and found that they are not evidence-based and cannot be advocated. Laura Kirkby in San Diego reviewed 567 vision therapy studies, and only 5 were actually on reading and attention. And of those 5, only 2 were even of moderate quality. So again, you do a study, you don't do it in the proper scientific fashion, you can make it show whatever you want it to show. I just want to show you this, and then one more slide. I made my financial disclosure. I'd like to make a financial disclosure for Erlin and the vision therapy advocates. They have a huge financial interest. I copied and pasted this from a developmental optometrist from the website. It costs between $500 and $800 per session. The programs on average run $2,500 to $8,000. It's not covered by medical insurance because there is no evidence that it works. And somewhere in here, they do an analogy that parents just need to cough up the money. It's sort of like needing braces in a child. I think that's in there somewhere, that it's just like needing braces. Anyway, this is what the parents will read. The role of the pediatrician is to help with the developmental screening, look for any speech or language difficulty. But by and large, these children will need a thorough evaluation by a pediatric neuropsychologist. I want to save some time for questions. I'm very sorry to blow through the slides at the end. You can certainly read through them. They will be online. Also online is the joint technical report, which backs up this entire presentation. And I also do have some resources at the end. I'll go ahead, I have 5 minutes. I'll take questions, please.
We don't have it up there at the moment. To the speaker, can you comment on reading problems abilities in children with ASD, autism?
No, I really don't. I really don't have that knowledge. Let me get back to you. My daughter actually is a research assistant at the UCLA Center for Autism and Research. I will ask her, and she will ask her colleagues. I'm sure that autism in itself, obviously, is going to cause reading and learning, just with the overall neurologic dysfunction, but I will ask her specifically what's going on there and what type of problems. That's obviously a very, very important question, as autism is now being frequently diagnosed and is extremely common. If you give me your email address, email me, I'll follow up on that.
I'll leave that to you. From Jackie Good, do you feel that children with learning disabilities at school need a comprehensive eye exam prior to proceeding with interventions?
Yes, I do think that all children should receive an eye exam. However, you need to be very, very careful if that child is then referred for vision training or colored lenses. You know that they're going in the wrong direction. You basically want to know, does this child have 20/20 vision? Do they have a severe visual limitation or not? So it's important to find out what the eye doctor finds. Once and really for over 99% of the kids who do receive a vision screen will, well, I shouldn't say 99, 95% will probably pass. So the majority should be passing and then be referred on to further evaluation, such as with a neuropsychologist. The other thing is that you have to beware the child who receives reading glasses. As I mentioned earlier, children have 10 times the ability to focus than a person who is 60. I have never seen a child given reading glasses and magically had their reading comprehension improve. There's no evidence that that does anything. Children, by and large, do not need reading glasses.
Quick question, reading glasses for near vision difficulties or convex lens?
Right. Again, it can happen. A child may need glasses to help keep their eyes straight if they have strabismus, but if you have a child who has 20/20 vision, no eye crossing, their accommodation is fine, their focusing is fine, reading glasses really are not going to do anything. Reading glasses are not a mainstay, are not a treatment for dyslexia. It's very unusual, very rare that glasses that you're going to have an eye or a vision issue that is causing the reading problem. It can happen, and that's why children should be sent to an ophthalmologist for a screening. But again, it's very unusual for that to happen.
And do we have any other questions? And please feel free to unmute as well and ask those verbally. Let's see, one more. Do you feel that children need evaluation from an ophthalmologist or optometrist?
Children with reading problems, my feeling is that a vision screening will suffice. Okay, so if a child is have a learning or reading problem, and they pass the vision screen at the pediatrician's office or at the school, probably can bypass the ophthalmologist, although the neuropsychologist may order an ophthalmology exam just to be sure. So if you've got a child who has 20/20 vision, distance and near, no strabismus on the vision screen, it's going to be really unlikely that they have an eye or a vision problem causing this. I would not have the ophthalmologist or the optometrist to be the first person that that child sees.
And we had one more come in. What is the wait time for a neuropsych evaluation at UNM?
Boy, I don't know. Very, very long. Like all pediatric subspecialists, we are very few and far between. The director of pediatric neuropsychology at UNM is Dr. Sherwood, and she is going, I actually spoke with her recently. She cannot possibly, I believe she's the only pediatric neuropsychologist there, she cannot possibly see all these kids. So she is compiling a list of other psychologists in the state who will be able to evaluate these children. And if you contact me, I'll be happy to share that list, or you can email her directly.
Okay, I don't see any other questions.
Well, any questions, contact me anytime, telephone or email. Thank you. I'd like to thank Vision for inviting me to speak.
Thank you, sir.
Thank you.
And thank you, everyone. If you haven't typed your name into the chat box, please feel free to do that now. We're going to go ahead and mute, and I'll keep my screen open to catch anybody else who would like to sign in. Thank you very much, everyone.
Hi, I'm Harin Kurasinghe. I'm been on the whole. What's the whole program?